I really appreciate you all for picking this session. You made a great selection of your options, so thank you all for joining us today in this room to talk about health equity and broadband for tribal communities and beyond. Really excited to be here and just really grateful for all of you for participating. Quickly, we'll introduce ourselves and then get started. I'm Aislinn Taylor. I'm the program specialist at the California Telehealth Resource Center. We are a nonprofit funded organization that provides no-cost digital health education and resources for all California providers, health centers, and patients alike. If you're interested, hit me up after the session. We'd love to talk with you. And that's me. We've been in California since 2006 doing digital health education, so a long, long time, and just really thrilled to be participating in this conversation.
Good afternoon, everybody. My name is Buck Ellingson. I'm a member of the Walker River Paiute Tribe out in Nevada and a policy analyst at the California Rural Indian Health Board. I just want to start by saying thank you all for coming to this presentation, hearing about tribal communities and the things that are happening with tribes. At CRIB, we handle a lot of policy and advocacy issues. We also operate a number of different programs for tribal communities and provide TA for, I don't know if I mentioned it, we have 59 tribes and 19 tribal health programs within our network. So thanks again for seeing you and look forward to discussion.
Halito, my name is Nanette Starr. I'm a descendant from Choctaw Nation of Oklahoma on my father's side from the Yandell family, and from my mother's side it's mixed European, primarily Scottish, from the Scottish Isles McFadden clan. And I work for the California Consortium for Urban Indian Health as the Director of Policy and Planning. And the flyers that you have, and there's some up here if some people in the back don't have them, that little handout was just a quick little fact sheet that we have from Sukui, and so I'll be coming and speaking on that behalf. I wanted to also get us started with just a quick land acknowledgement. So I am an uninvited guest here, and I would like to acknowledge the past and present of Sacramento area. This area was and is still the tribal land of the Nisenan people to the north, Miwok people to the south, and across the river to the west are the Patwin people. Between 1952 and 72, over 100,000 reservation Indians went through the Bureau of Indian Affairs, the BIA, their relocation program, and they resettled into metropolitan areas, including Sacramento. Many people continue to live, work, and maintain their families and extended families across the state in urban areas, thus adding to the urban Indian experience. And I'm bringing this up really to just root us in the land, not only to remember the people who used to, and many still do, occupy the area, but also to understand that in the lives we lead and often in the cities that we occupy, there are many Californian tribal people living today, and this is still their land. May we make decisions and move forward with our work in a way that is inclusive and accounts for the people who call this area home, and may we remember that many of us remain uninvited guests here. So let's do our best to be respectful through our decisions, through our work, through our lives, when we play. Thank you, Yakoke.
I'm Chris Mitchell. I'm with the Institute for Local Self-Reliance in Minnesota. How I came to be here is a little bit odd, but I'll tell it briefly. For 16 years, I've worked on local community solutions to make sure that everyone has high-quality internet access. Actually, slightly before the pandemic, but really accelerating during it, we recognized the overlap with internet access and health outcomes, and also roles of financial flows of money and how they're all interrelated. Then I was working with a close friend of mine, Matt Rantanen, who runs Tribal Digital Village in Southern California. And 2.5 years ago, he and I worked together to create what we call the Tribal Broadband Boot Camps, where through 11 different events, we have brought together tribes that operate their own internet service providers and worked with other tribes that would like to build their own to try and do a knowledge exchange and skill exchange and that sort of a thing. And so have become more and more focused on the challenges in Indian country. Kind of a number of different pieces pulling me in, and the ITUP has been wonderful throughout in terms of helping us to make sure that anything that we're doing on telehealth is not too embarrassing in terms of mistakes for the folks like you that actually know things about it. So I try to bridge that gap a little bit between telehealth, healthcare people, and broadband people, because I feel like my team is focused on that communication and helping people understand the other side of those challenges.
Great. Thank you. And I just want to quickly shout out that I'm very grateful to be moderating this session, and thank you to our speakers for being here to share your expertise and experiences with us today. All right, so today I'm going to be moderating, so I'm going to kick us off with a little background, and then we'll get into some questions and hopefully a really lively discussion. And there will be some time for Q&A at the end, so get ready. We'd love to hear from you all also. So I just want to quickly kick us off by talking about telehealth, digital health, and the advancements we've seen. The healthcare delivery system has continued to evolve to become more ingrained with tech. We see that, I know I'm the Telehealth Resource Center, so telehealth we're going to talk about it a lot today, but it also relates to remote patient monitoring, electronic health records, health information exchange, and access to healthcare education and information. Broadband is a huge component of healthcare today, and it is critical to ensure that tribal, American Indian, and Alaska Native communities have resources and supports to take advantage of these technologies and modalities and are not left behind. So, to kick us off, I would like to ask the first question: what value does digital health access bring to tribal and urban American Indian and Alaska Native communities? And that's for all of you, so whoever wants to go first.
Ladies first.
They're fighting for it.
I'll do it real quick. I'll do a really quick answer, and then they can figure out who's going to provide the real meat. Which is that one of the things I love about that question is in the broadband context, everything is always focused on urban versus rural, in the sense that there is no problem in urban areas and that we need to think about rural for broadband solutions. And so in terms of the value that we see, I think it is making sure that everyone has high quality access to healthcare, both preventative, and then I also think about recovering from interventions, and so the whole range of interactions with the healthcare system hopefully will be improved and offer more equity when it's available more broadly when we have high quality internet access everywhere.
So in terms of the value that digital health access brings to tribal communities, I think it's the same value that it brings to all communities. Better access to healthcare essentially means better health outcomes. If you're not struggling with a chronic disease or physical or mental illness, you're able to get up and do the things that need to be done in your life. If you are sick and dealing with a chronic illness, the last thing you want to do is get up and go look for a job and go to a place of employment that's going to help you support your life. However, living in this economy, it's absolutely critical that people are able to engage on that in the economy. And so if you have access to a doctor via telehealth, you can possibly get over some of the challenges that are immediate in your life.
Thank you, both of you, for that was really great. I'm just going to add the connectivity and specifically the culture piece. So one of the things I've heard a lot today in the larger auditorium and the other breakouts is the need to see people that represent how you represent yourself, to see someone in your own culture. And sometimes we already know that there's a workforce shortage. And so in Indian country, it's not any different. So that's very true. But how can we have providers that maybe, like I've also heard about big turnovers, actually with some folks I was having lunch with, specifically in tribal areas, and it's true with urban areas as well. How can we have people that look like the patients? How can we have people that represent or can speak in a way that you understand? And whether it's language, body language, or culture, and telehealth definitely provides that opportunity to have a much wider net than just like, I can drive 5 miles, I can take the bus to blank spot. So it provides a lot of opportunities.
Yes. And I just love, Buck, what you said about it is the same value as every other population, but it is a value for this community that really needs to be acknowledged and uplifted. So for Buck and Nanette, I'm curious, what is your experience for the way the digital divide and access to broadband impacts healthcare access for tribal and urban communities?
Yeah. So in my experience working with tribal health programs, it's been difficult to see telehealth and kind of go live within the healthcare space, and tribes not really having the opportunity to engage in it due to a lack of broadband. You know, as an Indian advocate and someone who works on policy all the time, I'm constantly updating our members about, you know, what's available. You know, the state within the last couple of budget cycles allows for audio-only visits for tribal health programs to be reimbursed for those. However, if you don't have a cell signal, you know, you can't get a visit. And in many locations in California, especially the North Coast, we have major challenges with just even basic infrastructure. And so in my experience, it's been great to see these new opportunities come online, but it's also been difficult to see, you know, the lack of infrastructure exist when it comes to rural and remote tribal communities. Thanks.
And I know there's a lot of pieces of this answer that we'll definitely talk about in some other places, but right now I work for Sakui, which is definitely urban Indian organizations. There's 10 of them across the state, but I've actually spent the past decade working for different tribal health boards and epidemiology centers in California and based out of Portland, which served Oregon, Idaho, Washington tribes, and then in Alaska for a few years. And during that time, I saw telehealth used in many different ways, and one of the first things that when I heard this question, I go back to what is telehealth and how do we provide it, because it's also interpreted in different ways. So the impacts, and I like that word also because it's pluses and minuses, you know, so there's a little bit of, I could see where it's growing and I can see where it's innovative, but I can also see where we have so much left to learn and to definitely apply. But a couple top things that I wanted to be able to share with all of you is in urban areas, and you know, it's thinking of the kind of, in urban, it's the same actually in rural areas, but thinking about some of the assumptions that we're carrying when we're thinking about those impacts. So does everyone even have a phone? Do they even know how to use it? Mm-hmm. Well, my papa has a flip phone and he can't even use his voicemail, right? So if somebody said, you have a telehealth appointment, no idea, he doesn't even know how to turn on a computer. Yeah. And then we also know that a lot of times families are multi-generational, and so where do you have privacy for an appointment? We've talked a lot today about behavioral health in all the different sessions. I don't want to see a behavioral health provider at all with all my family around. I'm not going to open up the same way, let alone a lot of private issues that are just for primary care. So when we're thinking about those impacts, one of the things I'm thinking about is transportation. I'm thinking about internet, which is definitely what we're talking about as well, but also devices and privacy. And there's ways that we'll talk about a little bit later on about how maybe some solutions for that infrastructure. I think I'm just going to stop there, Liz.
No, that's great. I love to see it, and it all does connect, really, when we're talking about it. Rural, urban, devices, we need the broadband, we need the devices. There's so many pieces we have to consider and think about. So I do want to go back to broadband and thinking about that. One of the things we've heard about this year is the Affordable Connectivity Program. There's some changes there. I'm curious, for you, Chris, what does the federal landscape currently look like? And with those changes, what effects can we expect on this community?
Yes, and I might just start a little bit broader to note that we don't know exactly what the internet access picture looks like in depth across the United States. We have a general sense, but the Federal Communications Commission has refused to collect accurate data as to where access is available. There is no data about pricing. There is no data about reliability. And so, you know, a lot of these issues, we pretend sometimes that we have a sense of how many homes have access, but we don't know. You know, last I saw, I think even some 20 to 30% of homes on reservations don't have a wired telephone. We know that I think roughly 50% of people living on reservations do not have decent internet access. But we have only rough estimates for a lot of this. When the federal government decided to put more money into this, it created the Affordable Connectivity Program, which is a $30 a month subsidy for most people, $75 a month subsidy for those living on reservations to lower the cost of home internet access or a wireless plan. And that plan will run, or that program will run out of money in April. There is very little hope that it will be continued. It may be resurrected at some point in the future, but we would expect to have some significant disruption. What does that mean? The state of California will lose $1 billion a year in subsidies. That's about how much flows into California from the Affordable Connectivity Program. A lot of homes will go from having reliable internet access, meaning that they will have consistent, always connected internet access, to some months not being able to pay it. I don't think we'll expect to see a lot of families just say, well, we won't have internet access anymore. It'll be more hit and miss. On reservations, we expect it to see it be even harder. A $75 a month loss means not only that some homes will not be able to pay, it also means that a fair number of the tribal ISPs will have trouble paying their bills because they were counting on that revenue. There is no sense right now that Washington, D.C., and I would say more candidly, although I have, if you follow me, extreme criticism for both parties and just about everyone, I will say that the Republicans in this case are the ones that are standing in the way of refunding the Affordable Connectivity Program, which at its best was a deeply flawed subsidy that mostly put money into Charter and Comcast pockets, as well as some of the wireless companies. So we have not taken this seriously, but we're about to lose one of the few tools that we have.
Yeah. I've, at the Resource Center, heard a lot of disappointment over the loss of this, so it's definitely going to have some effects. So I'm curious, continuing as we talk about broadband, community broadband networks, why are they especially well situated as a solution to broadband disparities for these communities?
Yeah, so community broadband networks, which we loosely define as being networks that put community needs first. And I say loosely because that includes networks that are owned by a tribal government. It includes city-owned networks. It includes cooperatively owned networks that sometimes cover both reservations and more broadly Indian country. Those networks are about paying the bills but providing the maximum benefit, as opposed to networks that are mostly about extracting as much wealth as is possible. If you look at a map of the United States of where we don't have decent internet access, not only does it include most of the larger reservations, but also it's the areas that AT&T, Verizon, CenturyLink, Windstream, Frontier have historically covered. We don't actually have a rural broadband problem. Rural areas that had electric cooperatives, telephone cooperatives, or locally owned for-profit family businesses often reinvested and have decent internet access today, even though they are very rural. If you look at North Dakota has far better internet access than much of rural California. And that's because it's cooperatives that had reinvested over the decades. And so, you know, the sort of the state of where we are and the importance of community networks is that we need a network that will meet local needs. And in the case of tribes, one of the things that's really helpful is if you're able to employ people that speak the language, if it has been able to be preserved. And so we just had an event down with Tohono O'odham, which is down in southern Arizona, and being able to speak the language there. Jemez in Pueblo in New Mexico, they were both talking about the ability to speak that language, to connect with elders, makes it much more likely that people are going to take service and be able to use it in a meaningful way. But beyond that, it's also a matter of, it's a lot of money. That money staying on the reservation, going back into employing people from the reservation. At Tohono O'odham, every single person there is O'odham, and they take a lot of pride in that they have a lot of jobs that they are providing with that resource.
That's incredible. I love to see that this recirculating back into the community. Great, so now we've covered some infrastructure, we've talked about broadband. I'd like to get a little bit into workforce and the staff. So I'm curious for Buck and Nanette, working in these communities, what are some barriers to using telehealth with the workforce?
Yeah. So Barriers to using telehealth. Well, in fear of stating the obvious, the infrastructure challenges exist. But even when telehealth is available at tribal health programs, they're not always quick to take it up and use it. Part of that could have to do with workforce challenges, but another piece of it is a reluctance by tribal health programs and their providers to use technology to reach their patients. One of the main things about tribes and tribal health programs is that they have an inborn trust with their community members, and they don't want to threaten that trust by making them uncomfortable with the device and having a visit with a doctor. And so it's a lot of providers I've heard are they're not interested in really using telehealth because they want to preserve that inpatient experience with their patients to make sure that they feel like they're being cared for. And so that, I think, is really one of the biggest barriers, is getting providers comfortable with using telehealth, and not just providers, but the patients. Something that we've talked about recently is that this is a really important issue as it relates to elders. Tribal communities really revere our elders in a big way, and so to ask them to do something that they're not comfortable with, it's kind of a no-go. So some of the solutions, not just to talk about the barriers, could potentially be to utilize like community health workers or another position to go out to an elder's home, show them what the device is, show them what the appointment's going to be like, walk them through it, so that when it is time for an appointment, that they'll be able to access that care. Yeah, I'll pass it off.
So when I was thinking about how the best way to answer this question, I was thinking about some more questions I just want to pose to all of you to consider. So how is the telehealth delivered? Because when I'm thinking about barriers, I'm like, which parts? Also, where are the workforce touching patients? So where are those touch points? And that's something that Buck just mentioned. It's not just like high-level providers. It's the receptionist. It's setting up the appointment. It's the IT person making sure that that's there. It's making sure that they have privacy at home. It's also making sure that it's the nurse, whoever they need for whatever appointment. And the third question is, what is the population of focus? So if we're talking about elders, there's going to be certain barriers that we're going to want to make sure that we identify and that we work through to make sure it's a good experience and that they come back. One of the things that we know, especially with a lot of chronic diseases, is it requires some continuous doctor appointments. And so how do we make sure that we connect them with the very first visit so that they'll go again? And that's the same with maternal child health. So we have a lot of times we have women who don't go until toward the end, like their last trimester, to go get maternal child health, to go to prenatal visits. What if we could use telehealth in that way? What kind of barriers are currently existing that we would want to maybe overcome in order to make sure that they could be a part? And maybe it's a phone call, maybe it's a text appointment. I mean, thinking about age. And behavioral health, I was also thinking of primary care versus specialty care. So in all of those, like there's all different barriers that I can come up with all of those different situations. Another one I really, really want to highlight is culture. And I'm going to keep bringing it up in probably all of the questions. But culture is a really, it's not that culture is a barrier, and I've heard today someone mention cultural competence, so I'm just going to plug this now. That's not my favorite word. I prefer cultural humility, because cultural humility means I don't know. It means please share with me about your culture. It doesn't mean I'm coming in, I went to a class, I know stuff. So how can we in the healthcare profession and how can others learn to have some of that cultural humility? Because you can learn some basic cultures, but I still don't believe that anyone can truly be cultural competent except for in their own culture. And even then, hopefully you're continuously learning from your elders.
And can I just highlight one that you said earlier that I think is often overlooked, both in urban and rural, which is a private space to hold it. You may have households that are larger than typical on the reservation. You may have intergenerational living, and people might not feel like they can get away from their family if they want to have a candid conversation.
Huge, great point. I think throughout this conversation, you're going to hear trust mentioned repeatedly, something that needs to be built, needs to be had for success with these visits, in person or virtual, but virtual especially, I would say. Yeah, that's a great point. I like to just highlight that telehealth access points are a huge thing. That's something we work on at CTRC is mapping, like, is there a place that they can go? Is there a room somewhere that has a safe space? It's so needed and is a new thing. So if you're interested, we do have a map where we're mapping some areas. And also at the Resource Center, something I didn't realize when we were doing a lot of our trainings is we do spend a significant of time building trust with providers and patients and demonstrating successes with telehealth and building that trust in the technology and the care. So it is needed and continually. So Chris, you have been co-running tribal broadband boot camps for more than a year now, some right here in California, really cool. Can you tell us more about these boot camps, who's attending, why are they so successful in tribal communities, and how can we get engaged in them?
Well, the tribal broadband boot camps are exciting and really emotionally rewarding for all of the attendees. We end each event, which feels like a mini summer camp. If anyone who's been that, where you just feel like on the first day you don't feel like you know anyone. On the last day you feel like you've known these people for a very long time. Like you have these bonds, and we end it with a kind of a reflection circle, and it's always fascinating to see how people use a moment of reflection as we go around. And so we see that it is rewarding and it strikes people deeply. I think one of the things that we look for when we're structuring it is to provide hope. Because a lot of people who are working on this feel like they are alone. They feel like they are, the phrase is reinventing the wheel, which if you listen to some of there's a woman who did a great book about this and said, actually, reinventing the wheel was super important. And we really benefited from reinventing the wheel over time. But the phrase nonetheless persists. But people feel like they're alone and isolated in doing this work, and meeting other people who have done it, seeing examples of how they've gotten to this. And one of the things that is really great is, women have done a lot of this work running tribal ISPs to the extent at which when we put a panel together for some of the tribal ISPs, it's hard to find a man because so many of the tribal ISPs are run by women, although many of the women face some discrimination from tribal leadership, and we've seen horrible instances of dealing with that. So it's this sense of like, oh, I didn't know there's other people out there like me doing this thing, and looking up and saying, all right now I have 3 people and I'm so excited about what we've done, but I want to grow the team to be like them and what they've done. So we do hands-on stuff where we're actually like build a working wireless network, or coming up in March, we're going to be building a fiber optic network with a ring, and I'm not going to get into what all this means, but we're going into actually doing the work, showing different techniques, and having people do it. But that's a part of it that draws people in, but really it's a psychological thing about building these relationships and networks, because once you leave the event, you're still stuck then trying to figure out how to make all this stuff work, figure out where you go for help. And so we try to build relationships there. And a lot of what we do is just try to give a lot of different people time to speak, to be heard. We build a specific culture of no question is dumb, and making sure people feel very open, because this is an area where all of us know tech people who use their knowledge like a weapon, and it's so harmful, and so we get by that. And then on top of that, I mean, I'll say that one of the things that we've learned is that if we bring in too many non-native people, it gets noticed.
Yeah.
And so the people who are coming, they want to see, even if it's the exact same words coming out of someone's mouth, they would much prefer seeing someone that has the same sort of cultural background that they do. Although it's greatly varied, there's still some similarities. So that's what we've learned a lot. As to how to get involved, it's hard. There's still smaller events. We do 6 a year. We scatter them around. But tribalbroadbandbootcamp.com, I think, and .org. I think they both end you up at .org. But tribalbroadbandbootcamp.org has some information on them. We do try to limit the number of people who are not directly working with tribal ISPs. So it's a little bit difficult. But we will be back next year, most likely, to visit Hoopa Valley again, because they've been with us from the start. They're about 5 hours north of here, and they're one of the most exciting tribes that has been doing. They won one of the largest awards to build the network. They're very aggressive, and they're super excited about sharing that. So we'll be back in California probably in 2025 now with them.
Awesome. Awesome. Really, really cool. Definitely go check out his website. It does look like an amazing summer camp experience, full of learning. I would love to participate also. Yeah, that's really awesome. Thank you for sharing. I want to kind of bring us back to trust in relationships, and I'm going to kind of go out of order. I have a question here, and it did say culturally competent, and I scratched that out, and then I had cultural concordance, and then I scratched that out, and now I have humility, because I really like your note, and I just kind of want to bring it back that it is okay to say, I don't know, It's okay to say, I don't know, it's okay, and to ask questions and to be open to learning. I'm doing that here today as a non-native person up here. I'm learning a lot, and I just really like that you mentioned that, because humility is key.
Can I just say one thing on that? Because I also, like, as a very, very white man, like, I have felt super awkward at times to be at the front of the room and that sort of thing. And members of my staff who have been wanting to help out, but also felt, like, is this my place and whatnot? That was always my answer, was that humility. And I would often just own up to it and say, I'm learning. Like, I am very open to being corrected and whatnot.
Yeah.
And I have never had a situation where anyone was upset with me or anything else because they saw that I was coming from an honest place, I think.
Mm-hmm. So important. So I'm curious, Nanette, when you think of culturally humble care, what does that look like in telehealth?
Mm-hmm. And thanks for asking that question. And I'm going to answer just based off of my experience, because I think it's going to be different wherever you go. So if you ever have questions, just ask the people that you're working to help provide services for. But in Alaska, we have a training that happens. I worked at the Alaska Native Tribal Health Consortium, and that is the main hospital that's actually in Alaska. And there is a training that's given to all providers and all staff at all different levels. So I'm trained as an epidemiologist. It doesn't matter. You go to this training, and they teach you just some basic things to understand. And I'm just gonna give the two examples that they give, because I think that it's sometimes something that you can listen for. People in different cultures speak differently. Like, there's different body language that means different things. There's different volumes or tonal that means different things. And in Alaska, a lot of times there is no words. And so there's been a lot of providers that have complained, like, I told this patient this and they never responded and they're not engaged with their care, like that kind of thing. When really, it's very much Yupik and Inupiaq, which are just two cultural groups. There's a lot of them up there. They use their eyebrows a lot, and so I have some friends, and they would teach me that. And it was the exact same thing, like when I first moved up to Alaska, and I was like, okay, what is it you're saying? And she's like, you need to learn to read my eyebrows. Like, so she would. Certain ways that you do the eyebrows is yes, certain ways is no. Some means I don't know, some means I'm checking with someone else. There's all this different language. It's also cadence. Cadence matters. And for as long as I've worked across all different tribal communities, but specific to the Pacific Northwest, cadence matters. Like, I learned to slow way down, way down. And even now, like, I was working out of Indian country for a few years, and I noticed that my cadence started going faster again. But now I can hear when people are speaking really fast. But what it looks like in, I guess I want to use the example of the Community Health Aid Program, which is in Alaska. And in 1968, it's the first time that it's actually was funded through funding that came through the Constitution. And the so think of community health workers, what we talk about a lot down here in the lower 48, and up there's an actual program. So there's like an accreditation. There's certain standards that everyone has to meet. You just don't show up and become a community health aid worker. You have to usually come from the community that you're wanting to serve, and they primarily use telehealth up there. So if you're not familiar with Alaska is much larger than the state of Texas. It's a very, very large, and most maps actually don't have it to scale. So that means that they use like a hub and spoke model for their healthcare system. So the Alaska Tribal Health Consortium, based in Anchorage, which was way south, think of that as the hub, and then the spokes go out to all the villages and all the different places. Well, most of the villages, some of them have clinics, a couple of them will have like a specialty type hospital, but it doesn't provide like long-term care. It doesn't provide in-depth surgeries. So that means that, are you really going to fly everyone, which is extremely expensive, and they're little tiny biplanes that aren't always safe with the weather. Are you going to fly them all to Anchorage? No. So they use something called telecarts. They're telehealth carts. And Afghan is one company. There's a lot of companies that make them, but it's the main company that they use up there. And these carts are managed by the community health aid workers. And they can do a lot of basic things that I don't even know about, but if you Google it, you can see all the different things. They can take basic vitals, they can look in the ears, they can do all these things. So there can be a doctor in Anchorage seeing the results of all of these things, all guided through that, what we would call a community health worker. But I do want to distinguish, because there is really specific training, and there's been a lot of pilot studies. Community health aid program, they're called CHAPS, have moved down to the lower 48, starting with I believe it was Lummi Nation was the first one. I could be a little bit off, but it is a northern Washington coastal Salish tribe, to pilot it. And so, you know, one of the wonderful things about our tribal nations is that they're sovereign, which means that they get to determine how the health is for their own nation and their own people. And so they get to go try some of these pilot tests out that maybe the state doesn't want to invest in yet, and maybe the feds don't want to invest in yet, or you know, maybe there's pushback from a lot of accreditation, especially medical accreditation boards, that we don't know that that's going to work. This happened a lot with the dental, because there's a dental health aid program also. There's also behavioral health aid program. So there's the CHAPS, the DHATS, and then the BHAPS. So all of these different programs provide different levels of care, but through someone who, all you have to do is have a high school diploma, and a GED can work as well. But it is certain training that's provided, and I was in that workforce training, and so it is really specific training. So it's not like, you know, sometimes when we hear we want someone to go provide services, we'll think, would I want someone who has blank level of schooling to provide services? But the way they truncate the information and what the people that graduate from these programs are able to perform is a very high level very quickly, and it meets a really big need. So that's going to be one example of how I see that care carried out.
Yeah.
These are people, and bring it back to the culture of humility, but these are people that are culturally competent. So I would use that word with them, just not with me. But they are people that come from the villages, and they speak the local dialect, and they know who the elders are, and they know who the leaders are. They know what guides the community. They know where to go to for help. They know where to go to for change. And they also have a skill set, and they can also advocate back to Anchorage, we need this, we're seeing this. So they're also all connected with one another, even across villages. So it's a whole network of people. Once you graduate that program, you'll meet everyone else who's in that program. And one other example that I wanted to share, and this is an example that isn't telehealth, but I think we can use this as a model in telehealth. So Grand Ronde tribe, they're outside of Portland. They have a really great, and there's a lot of tribal health clinics, and you probably know some of them here, that have maybe a model like this, where you walk in and it's a circle, the clinic is a circle, and you get all the different care you need. So if you go in for a dental appointment, but you say that you need something else, they'll immediately get you connected with a health appointment, with a behavioral health, with a nutritionist. They also have like an elder center where they go do events and stuff together. So if they start seeing some elders that look like they're isolated or depressed, they find ways to connect them. But it's all like, you might only get this person to come in one time. So how do you have that full body care? And so I keep thinking about a model like that would be really great with telehealth. Like, how can we pass the buck on and not be like, well, in another 3 months, we'll get you in down over here. No, that's what happens to me. So, you know, I know that those kind of things can happen, but then you lose people, you lose momentum, and especially a lot of people, for many reasons that we might end up talking about more, trust and responsibility, they don't, in historical trauma, they do not want to go to these doctors. They don't want to fill out another piece of paper or another form. And I'm going to just share a small story because I tell a lot of stories. So there's also a lot of our elders, especially here in California, they were here before ACA, before Affordable Care Act. They were here when they signed up for Medicaid, Medi-Cal, as American Indians, they had to put down what their assets were. They had to put down their property. And this is a story I heard very recently. And so it's making some of our elders not want to, I'm never going to fill out that form again. Because I don't want them to take my property and that's my land. And I'm sure some of you, hopefully all of you know that there's a big struggle with land and our tribal nations and tribal people in this country, across the entire country. So how can we get through some of those barriers by changing the way we do some of the different healthcare systems?
Yeah, can I just follow up on that last point? So you guys may not know this, but American Indian and Alaska Native people are enrolled at the lowest rates of any ethnic minority population in California. We're currently at about 55,000 according to state data. Part of that is due to trust challenges that we talked about. Another part of it is because they have access to tribal health programs. But back to your point, the asset elimination piece and helping elders understand that if they enroll in Medi-Cal, that they're not going to have, whatever they're planning to pass on to their descendants taken away is a huge part of this. And really, the only people who are suffering due to these low enrollment numbers are Native people themselves. As I said, it's about 55,000 out of a census reported 1.4 million. So it's really, really low enrollment, and really like tribal communities are suffering because of it. Thank you.
Okay, we heard a great example of workforce representation and how important that is for communities to feel trust. Again, bringing it back to trust, and whole person care is another great note, that we are serving a whole person, treating a whole person and not just individual conditions. So increased access is so key. I know we lightly touched on this in this question, but I want to revisit mistrust of the technologies, of the modalities, and kind of some strategies and opportunities to help bridge, speaking to elders, specifically the generational gaps, but what are some solutions, what are some ideas for building trust with these technologies?
Yeah.
And I'll start with you.
Sure.
Yeah.
So, as I mentioned, I'm a member of a tribe out in Nevada, and hence I get some of my care up the road at an organization called Chapaday. It's in Auburn. It's a tribal health program. Something that they've done is when you walk in the building, as you mentioned, it's kind of a roundhouse, and you can get different levels of care from different windows. But when you have a telephone appointment, they have tribal music playing. It might be, flute music from Mary Youngblood or, drumming, but it makes Indian people, I believe, just kind of feel more comfortable with who they're engaging with. They know that it's not, some canned hold music from Kaiser. It's something that they're familiar with. And so immediately they kind of let their guard down. They go, okay, this is for me. And I think that, you can deploy that tactic even with a screen appointment. You might have an elder telling a story about, the local tribal history, something that they're going to recognize and say, hey, that's me. I'm happy to wait and listen to this story and then, follow up with my care. But it's really about meeting people where they are, making them understand that the people who are serving them are like them and have their best interests in mind, and really kind of overcoming that trust barrier to provide the care that they need. Thanks.
Any points from you?
I really like that example. I like the example of, and that's something that I've also heard echoed throughout today, is about, is this for me? Does it look like me? Does that represent me? But I think another part of the trust is, and I'm going to go back to the touch points all along the way, from making the appointment and whoever makes that appointment, from what happens when they first call. Each step along the way can influence whether that person's going to feel like they are just a cog in a machine, or whether they're going to feel that connection. And there is something to be said that culturally having the whole body experience means a lot, which means don't sanitize me. So being able to provide, being able to check in, being able to meet the people where they're at is really key. And I was just thinking of I don't know if we're going to go into this, but a little bit more with elders, because that's what I think of more when I'm thinking of how to make sure that we don't lose that trust, or how can we help bridge some of that trust. Explaining things clearly and respectfully, not talking down to someone.
Yeah.
Using words like you would share with your grandmother, even if you're talking to someone who's 20 years old. And this is across this is not just in Indian country, but still, these are things that make it so that way it's us versus them instead of trying to provide care together, right? I think providing assistance along the way, seeing if, and that's why I'm going back to the elders, I hope that that's okay.
Yeah.
But don't make them ask, don't make people ask for help. See what kind of help they have. When we're going back and we're talking specifically about telehealth, sometimes it can be embarrassing for someone to say, I don't have my own laptop. I don't have my own phone.
Yeah.
I live in an urban area and I don't have internet. Sometimes the only place that you can get internet in urban areas is at a library. Well, that's not going to be private. You know what I mean? So being able, and also being respectful, I think another part of that trust is also the way that, and this is back to elders specifically, but how we learn and are trained from our elders to talk about our body, and in public and in which ways, I think really matters. So I think that's something that I didn't think about bringing up before, but also who's that first touch point provider?
Yeah.
So and if this is a female patient, it is important. They're not going to necessarily ask for a female patient, but those are some of those things that can show that there's some humility and even some competence. And competence not as in a ceiling, but competence is in like you did a little homework.
Great points. I heard both, like I would say, meeting people where they're at in terms of like how you communicate with them, education, and also representation. For me, I go to a doctor's office. I just got a new doctor, and I walked in, and I'm an African American mixed person, and I go in, and there's art on the wall that represents me and my culture, and it put me at ease. So I can see where music or art, conversations that are culturally representative just put you at ease and give you, a comfort where you do feel like you're in a safe space. Is so needed.
Can I add one more thing?
Yeah.
And I'm just thinking about, well, what's another part of the trust? And that's going back to the paperwork. Explaining what it is. And so I don't know about many of you, but I've helped my papa through a lot of appointments, and he's like, I just filled that out. Why do they have to know again? That's really frustrating.
Yeah.
Now, we understand that, and we're just like, you just have to do it. But there's a mistrust that's there, too. If I just told you something, why do I have to repeat it?
Again.
And he would get so mad. So I would just, he let me speak for him. So I would say, let me just tell them, and I would just do the repeat. But keeping in mind as providers, these are some things that you can also help improve in the processes, is the paperwork or who's gonna ask what, in order to have that plan for care. And I think that there's something that you lose trust, and I would almost say with probably a large number of people, can't speak for everybody, but I know for me, if I just told you this and I just saw you put something in the computer, why is someone else asking me?
Yeah.
You know what I mean? So
Yeah.
even some of these, make sure that you're following through with your word. I'm writing this down so that way the doctor has it. Well, then the doctor better be reading it. You know what I mean?
Great points. Great points. And that's something at the Resource Center when we're teaching our best practices we're considering is making sure you're communicating with the patient. I'm going to be looking away. I'm taking notes over here. I'm reading something, and just letting them know, communicating what's going on with paperwork. It's an administrative burden no one wants to deal with, especially a patient, and they want to feel heard. So I know we're a couple minutes in. I want to give a chance for questions from the audience, if there is any, and then we'll come back for some final points from our speakers. But if now is the time, I'm looking at y'all. If y'all have questions, we'd love to take some. The microphone is coming.
Thank you. Test is working. Yep, good. Is it possible that the teens in a tribal group can be persuaded to become almost ambassadors for telehealth? And I bring that up. I've talked to a number of folks from immigrant populations where the teenagers have a role that they play in large part because they are the translators and they're the ones that try to help the older folks, right? Is that a doable thing in tribal communities?
Yeah, great question, and thank you for posing that. I think that when they're available, they're always employed to help address technology issues in tribal communities. You raise a great point that a lot of elders, they didn't grow up with a cell phone. It wasn't like their first nature, right? They may or likely don't have a computer. My dad is, in his late 60s, and I bought him a tablet for the first time, and that was his first touch point on technology about, 3 years ago. So going from having no technology to having a tablet, now he can potentially take a telehealth appointment from that or from his phone. But having younger people around to help engage in that is really key. And so I think that those elders that are fortunate enough to have their kids and their grandkids around, they will employ them to help when they can. I think that if we did something like that in a more formal structure, it may be pretty effective in getting people to think about that as an opportunity to learn from younger generations to older. So thank you for that. Yeah.
I really like that suggestion also for building trust, because I'm thinking I can just see a bunch of aunties and one of them went to a telehealth appointment and then now maybe helps the others do their, don't worry, I'll help you get, and maybe it's still with the support of a community health worker. So you have that touch point for some of those things, but then having them be an ambassador, and then also considering some kind of incentive, like helping them out in some way, even if it's financial or there's grants, there is money out there, but maybe it's something where you're helping the community in that way, and then they're being that ambassador at all those different levels. Someone who's pregnant, so we have the maternal child health group, we have the youth group, we have the elders, we have men who don't maybe typically like to go to their doctor, very stereotypical. What if there was an ambassador for all those different levels, and they could speak to their own groups?
That's great. We call them digital navigators
Yeah.
at CTRC. There are kind of telehealth influencers in the community, and I love your point of, kind of separate or kind of having influencers or ambassadors in these separate areas, because there should be. You want to, you want the influencer that kind of relates to you to talk to about it. So that's great.
Yeah, and I would just add on two things. One is that there's no silver bullet. There's definitely, it'll work for some, and then for others, and so we need to have multiple touch points. And that leads into the second point, which is if people aren't aware, it's just a good time to note that Craig has done really important work with getting telehealth in barbershops in Black communities. So if people aren't familiar with that, Craig's done a lot of writing about that and some of the benefits of that. And so we need to have lots of strategies rather than just trying to figure out, is this the one? It's never going to be the one.
Yeah.
Right.
Yeah, we don't have a Neo here.
Good point. Questions? I think we can take one or two more.
Hi there. I'm with a nonprofit, Children Now, and we work in children's environmental health. And we didn't really touch on this today, but obviously land and just ecology is really important to the holistic health of tribal communities. And I guess I'm looking to see if you have any advice for CBOs or nonprofits that are looking to incorporate more traditional knowledge or work with tribal communities, and where to even begin doing that.
Yeah, that's a good question, but also a tough ask. You guys probably know tribal governments in California tend to be pretty small, and because they are a government, they have a lot of duties that they're trying to engage in, and so their capacity tends to be pretty limited. I have heard of some organizations actually hiring tribal organizations to provide some of that cultural informing. So it's if you know anybody from a tribal organization, you can always start there. You can reach out to me if you'd like, and I'm happy to connect you in any way that I can. It may be a tribal organization, it may be a tribal council member, or maybe even just a tribal member living the Indian experience. you learn certain things that aren't obvious to everyone else in the room. So yeah, I think that's a great place to start. So thanks.
And I'll share a couple other places that, as I've worked with lots of different tribal communities, and each time I go in, just, I'm sure you, well, maybe you don't know this, but every single tribal nation is unique. They're sovereign. So when you go to one, you're going to one. So even if I go visit all the different tribes, federally recognized tribes in Washington state, each one is a little bit different. And so one of the first things that I would always do is go check out their website. Almost all of them have a website, and they have a lot of information, and they have a lot of history. So if you start talking to them, you could say, well, I looked at your website, and then ask further questions. Admin people at Tribal Council office are a wealth of information about where else to go. Some tribes that are larger have their own cultural centers. Some even have their own museums. So it also depends on where you're talking about. And sometimes some smaller tribes have actually put some of their information together for you. And there's also a lot of books also. So there's like the book, The Tribes of the Pacific Northwest, for example. There's one on California tribes. Now, not saying that any of these are extensive, but it's a place to start, so that way when you go talk, you sound like you really do want to learn and you've actually done your homework, instead of like, I don't want to go look anything up, just tell me everything that I'm supposed to know. Yep. And also, why are you asking? And that's something that's come up to me a lot. Why do you want to know? You're not from here. What's your point? What are you trying to do? And that is a big trust issue, which I know we're not going to get too far into that. But there's also, especially when we're talking about traditional knowledge, I've worked in traditional foods for quite some time, and there's a lot of protection around traditional knowledge, because if they don't know who you are, then you're an outsider. And so what do you want to do with that information? Are you trying to benefit? Are you trying to build your own nonprofit? Or are you trying to expand in some other way? So being able to kind of check yourself, I guess that's the cultural humility part of like, where are you coming from and what are you bringing and who are you? And then just do some of the basic internet stuff and then contact Buck.
Just to follow up on something that she said too is, if you're planning to do some tribal specific literature or something, it's important to know about your local tribes. If you throw a headdress on something in California Indians are they're gonna be repulsed by it. You'd be like, this is not us. This is North and South Dakota and the plains, and you might do more harm than good and create additional barriers for yourself. So just doing a little bit of homework on, maybe checking out some local tribal websites, it will help to disarm them. But if you go about it in the wrong way, you might create additional barriers. So thank you.
All right, so sorry. I will just say, I know we're not going to have time for all the questions. This is a really great group. Chris, Nanette, and Buck are all really nice, friendly people. So if you have more questions, go find them, pester them, and ask your questions out in the floor. I will just close us out with an opportunity for all of you to leave us with one message you want to end with when it comes to addressing health equity and broadband for tribal communities. Leave your final word. I will say with mine, we're the California Telehealth Resource Center. We are funded by HRSA and the State Office of Rural Health to be here for a resource for you. If there's something you need with digital health, please reach out to us. And if there is a resource that does not exist that we can make happen, we want to help. So that's mine, and y'all.
I just want to say thank you to ITUP for including tribal communities in this discussion. Tribes tend to be small in California, but there are a lot of needs in tribal communities, and just inviting us is meaningful, and having the ability to have this conversation. Also, big thank you to all of you for showing up. You had other options, but you chose to come here, and that's really meaningful to me and the rest of us. So thank you all.
Yeah, echoing everything that Buck said, thank you all very much for coming. And just keeping in mind, and I've heard this as some last words from another speaker too, but making sure that the people that you're wanting to serve are truly represented. And if you don't know, and I'm really glad that you mentioned that, because also noted the teepee, noted the dream catcher, like just be careful, and if you don't know, ask or reach out to Crib or Sakui. We answer questions like that all the time, and it just usually takes a couple minutes to look at a photo and say that's not California native. So feel free to reach out, but having people that, like even like what you shared, like having something that represents you, otherwise it's not for me. Like that's the philosophy, to reach the people. Thank you for all the work you're doing.
And I would just wrap up by saying that if you work in healthcare and you hear that connecting people to broadband is too expensive, you should not believe them. The costs of not giving people healthcare opportunities, not giving them educational opportunities is far greater than the costs of connecting everyone to broadband. We're talking about thousands of dollars to connect a home of one-time costs and a few $100s per year to keep it going. In healthcare talk, that is nothing. It's a rounding error. We can deploy our resources better to make sure everyone's well connected and then use it for greater healthcare opportunities as well as additional opportunities beyond that.
Much for being here and joining us. Last reminder, do your satisfaction survey. It's really important. I've been told a lot, so please do it. Thank you so much. Thank you all.